My name's Alice Park. This is my podcast assignment on type 2 diabetes mellitus. Introducing Jane Doe, 32-year-old female with type 2 diabetes. She's 110 kilos at the moment and her height is 170 centimetres, which makes her BMI 38.1 and makes her obese. She does not exercise at all at the moment. She works in superannuation, which is fast-paced but mostly desk work. She has a long-term partner whom she's living with and she's very happy. Social history-wise, her mother also has type 2 diabetes and both of her parents are overweight. She's not pregnant at the moment and reproductively speaking she has polycystic ovarian syndrome. She does not smoke, rarely drinks and has been prescribed metformin. In someone with type 2 diabetes like Jane, there are changes to the physiological processes surrounding blood glucose control. In a normal, healthy person with type 2 diabetes, insulin synthesis appears as in that top image, where insulin is synthesized and stored only by the beta cells within the pancreas, a process which is triggered by a spike in blood glucose levels. In Jane Doe's instance, her peripheral tissues, if you just look down the bottom there, such as muscle and adipose tissues, they've lost their sensitivity to insulin, either due to a drop in receptors or a cell derangement. This means that blood glucose levels are staying up, so that the pancreas keeps on producing more and more insulin. Eventually tiring, the result is beta cell dysfunction and even complete exhaustion of this synthesis, resulting in a decreased or total lack of synthesis overall, as in that bottom image. Insulin release is also damaged in the type 2 diabetes patient. As can be seen on the left, normal insulin release from the beta cells happens when there's a spike in blood glucose levels, say after a meal, and it takes place in two stages. In the first stage, stored insulin is quickly released as a rapid response, and then in the second stage, storage insulin has run out, but blood glucose levels are still too high, so the pancreas synthesizes more and releases it until the blood glucose levels have returned to normal. In Jane's case, decreased sensitivity of her tissues combined with increased blood glucose levels mean that there is less opportunity for the pancreas to store anything, resulting in a loss of that first phase release and a reliance only on the slow second phase release, which may not even be enough to lower blood glucose levels. Conversely, often at the beginning of type 2 diabetes, insulin release is far more increased in comparison to a healthy individual. This is the pancreas quickly trying to compensate and combat the decrease in insulin sensitivity in the peripheral tissues, and then that's what burns out. So the key therefore to managing type 2 diabetes is blood glucose management. If Jane doesn't stay on top of managing her blood glucose, she could suffer from hypoglycemia and hyperglycemia long term as well. She's more likely to endure strokes as a result of this, because increased blood glucose levels cause accelerated atherosclerosis development, as it damages the endothelial cells in the tunica intima of the blood vessels, which initiates a chain of events that leads to an atheroma, an overall occluded vessel, then potentially thrombus or embolus development, and ultimately, if this is taking place in a cerebral vessel and there's occlusion, there will be ischemia and cell death in the brain. She's also likely to have a hemorrhagic stroke as well, because this vessel weakening caused by atherosclerosis can also cause aneurysm, and these aneurysms can burst. So this ability for blood glucose levels to increase atherosclerosis also contributes to her risk of angina pectoris, as on the right there. This is when that plaque develops, but it's in her coronary artery, and it obstructs the flow of blood and oxygen leading to the heart, forcing it to go into aerobic respiration if there's any demand placed upon it. So this process releases adenosine phosphate into the chest, which causes pain and discomfort for Jane, which we know to be angina pectoris. So Jane's been prescribed metformin for her diabetes, which is an oral hypoglycemic drug of the biguanide class and a common first-line therapy. It's a great choice for Jane because it's one of the type 2 diabetes treatments options that is thought to help patients lose weight, or at the very least not gain it as a side effect. At Jane's current weight, she could really improve her overall health. It's also used in women with polycystic ovarian syndrome like Jane, as it's been shown to combat some of the impacts to both weight and fertility. The mechanisms of action for metformin is that it overall reduces blood glucose levels, which is obviously needed in Jane's case as her insulin sensitivity is down and her blood glucose levels are up. Metformin does this in a number of ways, some of which still remain a bit mysterious to scientists, but that do include 1. They inhibit hepatic gluconeogenesis, therefore working against glucagon in the body. Metformin also reduces the uptake of glucose in the GI tract, and it increases the efficiency of those peripheral cells to uptake glucose. This is all appropriate for Jane. As mentioned, her insulin is not performing its task adequately in lowering her blood glucose levels. So metformin now is stepping in and assisting in this regard. Another way Jane is trying to combat her diabetes is by soon beginning an exercise routine. Physical activity could help her reduce her weight, which would increase her peripheral tissue sensitivity to insulin and improve her blood glucose management overall, maybe reducing her reliance on metformin. Additionally, exercising skeletal muscle actually doesn't require insulin, meaning that the glucose transporters in the cell don't need any insulin to uptake glucose from the blood. The net result is they're able to take glucose out of the blood into the cells, lowering those blood glucose levels. These levels are measured over time by the HbA1c test, also known as the glycosylated hemoglobin test, which is a blood test that measures the long-term levels of glucose as it's attached to hemoglobin. The higher the percentage, the more glucose there's been in the blood. Less than 7% would be considered ideal. For Jane and for her doctor as well, this test is really useful in managing her disease, as it provides a reliable measure of her adherence and the success of medications and lifestyle changes she's undergoing. It's more reliable certainly than patient self-reporting. It also provides a great measure for goal setting and motivation. For example, Jane might say to herself, I want my next HbA1c test to be better than my last. This might be a decision that she makes that can improve her health. And here is my annotated bibliography. Thanks for listening.